Ladies and gentlemen, welcome to this latest teaching session in the course on technology and the future of medicine. Today we have a very interesting presentation on Singularity and the Have-Nots, observations of a Canadian cardiologist in Nepal. I just want to make one brief remark before that. We now have great clarity on what we're doing the evening of December the 3rd, which is the last day of class. It's largely a party. There are two of you presenting that evening, but everything else the whole evening is party-ish. So I hope that you approach it that way and come planning to have fun and bring friends and associates as you wish. But I've assured the musician, Joel Crichton, that it's going to be a really spirited evening with happy, engaged students. So I hope that you can do everything in your power to make that happen. Otherwise, it'll look like I've made a serious strategic error and that I should have canceled the party because we could have done all the student presentations sort of in regular class time. So I don't want you to allow this idea that this was a strategic error on my part to have the party on the 3rd. Okay, so back to serious stuff. Bibiana has a great deal of value to tell us about Nepal, the medical needs there, what it's like to go there, and how that fits in with the idea of the technology and future medicine course. So, Bibiana, take it away.
Well, thanks very much, Kim, for asking me to talk to you again this year about a country that I've been to 3 times, and where really technology is sadly lacking, but other basic needs are also shockingly lacking. And just before I start, I just want to ask how many of you have been to a low-income country? So pretty much all of you. Okay. And what were you struck by when you how many were in South Asia? So 5, 4. South Asia is like India, Nepal, Bangladesh, okay? How many were in sub-Saharan Africa? So a few there as well. So I mean, you have wider experience than I do, because Nepal was really the first low-income country that I'd ever traveled to. I'm a cardiologist here at the Alberta Heart Institute, and really I've worked in cardiology for 30 years in Canada, from Quebec to Alberta, I guess, is the furthest west. And it was quite a shock to go to a low-income country. So I'm just going to describe my observations of life and healthcare in Nepal. I've been there 3 times. I'm involved with a medical school there, and Dr. Soles was one of the original people who started working on developing this new medical school that has a focus on developing physicians for rural medicine. And then I'm going to talk about, technology in a low-income country and the many, many hurdles, and how, although we've benefited so much from technology in developed countries, really hasn't been the case in low-income countries. So just to help you situate where Nepal is a small country that's between 2 giants. China's in the north, and India's in the south. And the country of Nepal has basically 3 different areas. The north is the Himalayas, the mountains. And then the hills is the central part, where the Kathmandu Valley is located. And then the southern part is the Terai, and that's more farmlands, plains, much like northern India. And you can see Bangladesh is very close by as well, and Bhutan. So comparing the population of Nepal to Canada, it's really quite similar. Both have about 30 million people, but the literacy rate is still very low in Nepal. So there's different definitions for literacy, but looking at the people over the age of 15 who can both read and write, that's 71% of males in Nepal and 47% of women. Whereas in Canada, of course, that's 99%. So Nepal is one of the lowest countries in the world in terms of literacy rates. And then looking at life expectancy at birth, for men it's 65 years and for women it's 69 years. And that puts Nepal in 168 out of about 180 countries. The number of countries varies as well. But very poor life expectancy, despite major progress that has been made in the past 10 years. And then infant mortality is still really high. Infant mortality is the number of children who die before they, children born live, who die before they reach 1 year of age. And overall, it's 55 out of 1,000 children will die before the age of 1 year in Nepal. And that ranges from a low of 33 in Kathmandu and 99 in rural areas, like in the mountains of Nepal. So very high infant mortality, although it has also improved recently because of a large focus on maternal health. But Nepal, of course, is a very beautiful country, and the Himalayas, 8 out of 14 of the highest peaks in the world are in Nepal. So people come from all over the world to climb and now to trek in the Himalayas. And Nepal in the past year got more than $1 billion in foreign aid. And despite all this money that's come into Nepal, many people feel they're worse off now than they were 30 years ago when they had much less contact with the outside world. And everywhere you go, you just see a lot of garbage now and motorcycles and pollution. So definitely changed, and probably not for the better. So this is an example of foreign aid that's kind of not well thought out and really not really viable for the long term. You've probably heard about Lukla. That's the city, the little town. It's not really a city, it's a little town that you fly into if you're going on the Everest base camp trek. You fly from Kathmandu to Lukla, and that's the runway, and you know, the pilot, and often there's clouds rolling in off the mountains, and if the pilot misses the runway, basically crashes into the side of a mountain. Or if a bird flies into the propeller, like often happens, that happened 2 years ago in Kathmandu, again the plane crashes. So, I mean, the risk of life is just so much higher in these countries. And in this small town has gotten a lot of international aid because Edmund Hillary, raised a lot of money for the Sherpas from around the world. And there's a Swiss NGO that built a beautiful hospital in Lukla, but when we walked by it, there was a gate that was locked and there was no activity in this brand new hospital because they just didn't have the people to run it. So, you know, a lot of people like to build things or donate in a way that would be helpful in our own environment, but in other environments it really is not useful. So it's really hard to give aid that's sustainable and technology that can be used. And then of course there's great geographic challenges in Nepal. So, you know, when you're there after Lukla, so you fly into Lukla and then there's no cars there, there's no roads. Basically this is the path between villages, and people carry these very heavy loads, like up to 60 kilograms on these very narrow trails, and they wear flip-flops as they're traveling along. So if someone is sick in one of the small villages and needs to go to Lukla and be flown out, well, 4 people carry them on a stretcher over these small paths and across high mountain passes. So it's very different from what we have here. And then the tea houses and little homes in the villages, well, they're very, very primitive. I felt much like I'd been transported back into the Middle Ages. People cooked over small fires in these houses, and some of them had chimneys, but they actually blocked off the chimneys to retain the heat and the smoke. And you know, this is at high altitude, and so you get really short of breath when you're sitting in a tea house like this that's full of smoke. And people have a lot of chronic obstructive lung disease because they're inhaling all these macro pollutants. And the homes are, you know, this is a nicer tea house that has a wooden roof, or a lot of them have tin roofs or just plastic covering. And some are built of stone, some are just sod. So, but the mountains are definitely very beautiful. But the people there perceive the mountains as a hardship mainly. It's just difficult to eke out a living at high altitude where the land is not very fertile. So tourism has been a big boon to certain parts of the Himalayas. And then there's like total lack of sanitation. There's no toilets. The outhouses in these little villages are like pretty much you wouldn't want to go in there because the wooden slabs are rotted, so you're afraid of like falling in. So it's like pretty horrible. So just open defecation out in the fields, and then of course people get water out of the streams, and diarrhea is rampant, and local people die on a regular basis from dysentery. So it's very different. Now, as tourists, of course, you know, we come with our health insurance and evacuation insurance. So when I was on this trek in 2010, we met a trekker from Germany who was very sick because of gastroenteritis. And as soon as the weather cleared enough, the helicopter came in from Kathmandu to evacuate this trekker out to Kathmandu. And later on, as we were coming back from our climb, one morning when we got up, I found out that one of the porters from one of the British expeditions had died overnight. And the porters don't actually, they're not Sherpas usually, they're not used to high altitude, they come from the Terai, the lower elevations, and this to them is a wonderful job to be carrying, 50, 60 kilograms at high altitude for 2 or 3 weeks. And this porter had high altitude pulmonary edema. He was feeling unwell, and he told his friends just to leave him alone so he could rest for the night. And then when they came back in the morning, he had died. And so they carried his body out to Lukla, and his family was coming in to pick up the corpse. They usually cremate them. But just cultural barriers. They could have come and asked the international trekkers for help, but the porters don't speak English. It's usually the Sherpa and the Serdars, like the local guides who are leaders of the expeditions, who speak English and who interact with international tourists. So like many people, people come to Nepal because they love the mountains, and then they meet the people there. And what really impressed me is despite all the hardships they face on a daily basis, they're really quite happy and, happy to see us, happy to play together. These two men up on the top center have climbed, they're both Sherpas, and they've climbed Everest several times. And in Canada, when we have a Canadian who climbs Everest, it's like a big deal. For these guys, it's just a way to make a really good income. And, some of the Sherpas have been up Everest 30, 40 times. These guys are relatively young, and they've only been up like 5 or 6 times. So just a very, very different reality. They take a lot more risk because they would like to have a more comfortable lifestyle and have a better income. So the other 2 times I spent my time in Kathmandu at the hospital, and Kathmandu is this big sprawling city. And nobody knows the exact population of Kathmandu, probably around 1 million, but about 5 million in the entire valley. And there's always like smog that hangs over the city. And you can see the hills, and once in a while you see the glaciated Himalayan peaks. But it was quite a shock for me when I first came to Kathmandu, because I imagined Nepal the way it was described in the 30s and the 40s in the early explorations, when it was kind of a pristine kingdom. But now there's like garbage everywhere, because of course they've adopted a lot of our Western ways, but they don't have the resources to deal with the garbage that we produce, right? So everywhere you look, there's garbage in the street, and then people will kind of collect their garbage and burn it in the streets, and that's pretty bad too because of all the smoke. And there's dogs and monkeys and cows wandering around. And I don't know if you could see it, but you could see some electrical wiring here. Well, the electrical wiring is just like broken wires dangling down. So land phones they were a scarcity in Nepal, but cell phones have been wonderful. Everybody has a cell phone. It's extremely important. So this was the hospital where I've been going for the past 2 years. It's the Patan Academy of Health Sciences. Patan is a neighboring city to Kathmandu. And I was going there to teach in the cardiovascular block, and it's really been quite an eye-opening experience for me. So in addition to lecturing and preparing like cases for small group discussions, we do this problem-based learning, and this was my group last time I was there, which was in September of 2012. And the students, you can see these are first year, these are students who are kind of at the end of first year of medicine. They're very young, they come directly into medicine from high school. And English is the language that's spoken in Nepali universities, so that's very convenient for us. But some of them who come from rural areas, they have some difficulty understanding English. They speak very quickly though, so it's hard for me to understand them as well when they're talking English, because the intonation is quite different. And this is Ken Lukowiak, who's a neurophysiologist from the University of Calgary, who's also visiting at the time that I was there. And it's just, they're very different students compared to Western students. They memorize really well, so they'll recite like paragraphs out of textbooks, but then it's just really important to question them to ensure comprehension of this material, because it's not so easy for them to like say things in their own words, or to summarize, or to apply this information. So different style, but they're very enthusiastic about learning, just always offering to answer questions, or even if they're totally wrong, they're just not embarrassed, they're just fine with it, and yeah. Well, life near the Patan Hospital was very different. This is where we lived, in the bottom floor of this house that's owned by an ex-Gurkha soldier. So the Gurkhas make a good income when they're working for the British Army. And so he was able to buy this beautiful home. And the water would come from these deep wells. It would be bottled. But we would still treat the water with Pristine, because I wasn't ever really sure that it was sterile. Very easy to get the water contaminated just from the big plastic jugs that they're in. But even though we were in a big city, a lot of it was kind of much like being in a country. Like there were chickens and hens, roosters that you'd hear every morning. And people had a lot of celebrations and music out in the streets. So it was kind of a low-tech lifestyle, but it was pleasant in many ways. The hospital itself is one of the largest hospitals in Kathmandu. It was established in 1953 during a cholera epidemic. And cholera is still ongoing in Nepal. It's a big problem, just because of the dirty water. Large obstetrics, pediatrics, and orthopedics departments, that's usually when Nepalis come to the hospital, when they're having a baby or if they have trauma. So orthopedics is very important. They don't come for health maintenance or minor problems. They come when something really major is going on. This is a government hospital, but 86%, the government is just basically chaotic in Nepal, and I don't know that people actually pay taxes, and I don't know where the government gets revenue from. I know that the hospital occasionally will get some money from the government, but it's not on a regular basis. So most of the revenue of the hospital comes from patients and from donations. And there is new technology at the hospital, like echocardiography, which is what I do, cardiac ultrasound, and some endoscopy, so like gastroscopy, colonoscopy. They have an intensive care unit with old ventilators, hemodialysis, because kidney failure is becoming more common. But when equipment breaks down, there's basically no replacement, and they just wait for another international doctor to come by and bring over something from Canada or the UK or wherever. So it's just a very different way of working. I mean, you don't plan for things because you never know what might happen. And you just hope that things don't break down, and if they do, well, that's just the way it is. So this is when I was doing echocardiography there. I worked in the medical school and then in the hospital as well, doing cardiac ultrasound. So they had this equipment that was quite old, and it came from China. It was just kind of not a very good machine compared to what we have here. The image quality was pretty bad. But during my first visit, I was able to train one of their doctors. So, you know, whenever we go to a place like this, there's no sense in me just doing the test, and then when I go, the test isn't available again. So we try to train the people who are there. And there was an internist who worked in the intensive care unit and another general internist who were very interested in learning echocardiography, and that went really well. But on the second visit, the transducer, like this part with the ultrasound crystals in it, was broken. So we had to use a pediatric transducer, and that didn't work very well. So it was just so much more challenging to do this test. And you know, this is not really considered high tech. This is kind of more of a low tech type of procedure. But yeah, when it breaks down, you just have to wait for years sometimes to get a replacement or a part. So just to give you examples of like what a shock it was for me to be in Nepal. This is kind of my typical Canadian patient with heart disease that I deal with here in Edmonton. So this is a patient that I had for more than 10 years. He was 66 years old when I last saw him, and he had multiple risk factors for heart disease. He was obese and diabetic and had high blood pressure and high cholesterol and a former smoking history. When he was 52 years old, so 14 years before he died, he had a large heart attack. And this was treated with thrombolysis. So streptokinase is a medication that dissolves clot. And then he had angioplasty. So, you know, streptokinase is pretty low tech and should really be available all around the world. Angioplasty is definitely more sophisticated. So after this heart attack, he had a moderate degree of decrease in heart function. His ejection fraction was 35%. And he did pretty well for about 6 years. And then he started developing angina, so chest discomfort with exertion. And he had another angioplasty done. And then 8 years after the heart attack, he developed heart failure. So he was short of breath with minimal activity. And he needed all these medications to improve his heart function and prevent fluid in the lungs. So lots of medications. And in countries like Nepal, people wouldn't take this kind of medication on a daily basis. Medications are pretty cheap. They're actually very cheap and easy to obtain from pharmacies without even a prescription. But just the thought of taking something every day to prevent a problem is kind of foreign to them. They're used to just, when they have a broken arm, they'll go and get that set. But the chronic diseases like diabetes and hypertension that require long-term treatment, they're just really, they don't have that kind of, they just don't think it's necessary to take medications on a regular basis or to see the dentist unless you have a toothache. So anyways, this patient with heart failure, he had a very sophisticated device because of his decreased heart function. He had a defibrillator and a specialized pacemaker called cardiac resynchronization to improve the synchronicity of contraction of the heart. So, you know, it sounds high tech, but it's really fairly commonplace here in Canada. But with technology, you know, it kind of leads to different problems. I would say it could save your life, but for a period of time, but it leads to different problems. And his device became infected, so that he got 6 weeks of antibiotics, the device was explanted, a new device implanted. And then he had worsening heart failure, frequent hospital admissions, and his kidneys weren't working well. And then his heart, just because of all the scarring in the heart and the poor heart function, the heart became very irritable, and he had a lot of ventricular tachycardia, so just really fast heart rhythms that result in basically cardiac arrest, but he would get shocks from his defibrillator to get him back into a normal rhythm. So he was doing really poorly, and at this point in time he was assessed for a heart transplant, but his pulmonary artery pressures were too high and his kidney function was too poor, so he wasn't a candidate for a heart transplant. So instead he had like a mechanical heart implanted, a left ventricular assist device, and he died a few days afterwards of complications. So this is kind of our typical Canadian patient. The care, these are chronic diseases, chronic risk factors. Heart failure is a chronic disease that requires a lot of medications, patient education, lifestyle changes, very costly over time. Like in addition to the medications, he had angioplasty, he had 2 defibrillators put in, he had an assist device implanted, so very expensive treatment. In his case, like probably at least $500,000. And then contrasting this with a patient that I met at the Heart Institute in Kathmandu. So this was an 18-year-old man who was dying of heart failure, and he was a charity case, so basically his family had no money. And it was whatever the government hospital could spare in terms of providing care for him. And he had recurrent admissions to hospital because of heart failure, and he had a lot of loss of muscle mass. He was very thin, and he had a valve problem, severe leakage of the mitral valve, and it's related to rheumatic heart disease. So that's basically an infection to which the body mounts an immune response that destroys the heart valves. And he was only 18 years old, but he already had several bouts of rheumatic fever that completely destroyed his mitral valve, and his left ventricle had become enlarged and wasn't contracting well. So his heart was so weak that mitral valve replacement was really no longer an option. And really his family couldn't come up with this kind of money either. So he basically was probably only going to live a few more months and die in the hospital or at home. There's certainly no long-term care in Nepal. Families have to look after their sick relatives. So really, this is an example of poverty and social inequity. And rheumatic heart disease is very rare in developed countries, in medium and high-income countries, but it's still rampant in India and in sub-Saharan Africa. So, such different faces of heart disease. In Nepal, patients are young. Their heart disease is related to an infection that really hardly occurs in Canada anymore because of better living conditions mainly. The cost of care is really cheap if you can prevent the rheumatic fever with penicillin injections. Whereas our Canadian patients tend to be older, their problem is more like aging and atherosclerotic disease, and the care is very expensive. And you see all the high tech that we have in medicine, it prolongs life, and it helps different organ systems, but eventually, like, things just keep breaking down, and more care results in long stays in the hospital, very poor function, dependence on high tech, like dialysis, like assist devices. And really, it's pretty bad quality of life in many cases. In Nepal, infections are still rampant because of poor sanitation and pollution. 50% of deaths are still related to infections, maternal perinatal deaths, and malnutrition. Diarrheal diseases are very common, and as are acute respiratory diseases. Vector-borne diseases, so borne by insects or other organisms, are common. Malaria, leishmaniasis, filariasis, so these are like worm infections. Japanese encephalitis, dengue fever. Tuberculosis is endemic. HIV doesn't seem so common in Nepal, but there's really no database. So we don't really know what people die of. And there is increasing diabetes, hypertension, cardiovascular disease, and cancer as life expectancy has increased in Nepal. So there's a number of factors. So in addition to the rheumatic heart disease and the infections, now we have more degenerative diseases as well. So with the aging of the population, people aren't dying in their 30s and 40s anymore, so they're more likely to develop coronary artery disease as they get older. And urbanization, as people move from country villages to the city. City is more polluted, they're exercising less, they have more diabetes and high blood pressure. The diet is quite fatty and salty, not as bad as in India, but still they tend to have a lot of salt in their diet. And then smoking is pretty common among men in Nepal, and the air is very polluted because of diesel trucks and just burning garbage and brick factories. And there also seems to be a genetic predisposition among South Asians for coronary artery disease that's particularly virulent, like it's just diffuse atherosclerosis in small coronary arteries. Those are the health challenges. But really, to try to improve the health of a country, you have to create a better society. And these are the major challenges for Nepal. First of all, they've had an unstable government since the Civil War ended, I guess, and before, since the monarchy. And corruption is rampant. So everything functions with bribes. So about a year and a half when I was there, they were talking about having to close, there's one large runway for international flights to come into Kathmandu. And they had to close that runway to repair it because a big sinkhole had come out on the runway. And that runway had just been redone a year before. But the problem is the company who did it had to pay such a huge bribe to the government to get that contract that they used shoddy materials. And that story just keeps repeating itself. So corruption and unstable government is a huge problem. Lack of a reliable infrastructure. So the same thing happens with roads. The roads, intermittently, they're washed out or there's sinkholes. These aren't just potholes, right? These are sinkholes. These are huge holes. So they swallow up buses. It's very scary. So travel is very hazardous in Nepal, not just in the air, but on the roads. And then electricity. Well, in the summer months, there's more electricity because it mainly comes from hydropower, from the runoff from the mountains. But in the wintertime, when things are frozen, there's blackouts that last up to 18 hours. So you have electricity for 6 hours of the day, and the rest of the time, there's none. And they have rolling blackouts throughout the city. So one side of the street may still have a little bit of lighting, and the other side will be in a blackout. So that's a huge problem for technology when you don't have a reliable power supply. Living conditions are very crowded. Like people live in these small apartments, very small, crowded together. So infections are spread very easily. Poor sanitation and lack of safe drinking water, so lots of diarrhea. Nutrition, well, the nutrition, they eat a lot of rice and they eat a lot of lentils. Like that seems to be what they eat pretty much all the time, and vegetables. So, in general, the nutrition isn't as bad as it is in other parts of the world. But if there's a famine in the Terai, then of course they have no food. And in the mountains as well. It's whatever they can grow. And there's been so much deforestation in the hills, in the Kathmandu Valley, that the soil is very poor. Pollution, well, I was just stunned at the pollution in Kathmandu. And then I realized, I think one of the hallmarks of civilized societies or higher income societies is the ability to manage garbage. Like that's actually something I'm so grateful for. When you go walking in Kathmandu, your eyes start to sting and the snot from the nose becomes black. And that's just because, the air is so polluted. So airway pneumonias and bronchitis and chronic obstructive lung disease, emphysema, bronchitis, are very common in Kathmandu. And then there's vulnerability to disasters. So, floods in these mountain villages, landslides. Kathmandu Valley is an earthquake zone, so can't do much about that. But they're home, and now they're starting to build higher buildings as well in Kathmandu. So there will be more people dying when there's an earthquake. And then, related to the unstable and poor government, social and health inequities. So there's really no government-sponsored healthcare, minimal. So it's just pay for whatever services you can afford. So I did visit the National Heart Center in Kathmandu during one of my trips to Nepal, and I was actually really impressed with this facility. It is a government facility, but really state-of-the-art technology, a good number of beds, a lot of intensive care unit beds, because people generally come when they're really very sick. And they do a good number of surgeries, but most of their surgeries, like in Canada, most of our surgeries are bypass surgery because of the prevalence of coronary artery disease. But there, they do mainly valve replacements because of rheumatic heart disease. And they have a lot of congenital heart disease as well. And that's because of infection and poor nutrition of the mothers, for the mothers. They had cardiac catheterization laboratories. They had very nice echo machines. They had electrophysiology. But they only ever did like the procedures where you got the most bang for your buck, and I was really quite impressed with that. We do a lot of procedures where there's marginal benefit, like the person is really so sick, doesn't make that much of a difference often. But there they do procedures where, it's a one-time deal and you can actually cure the person if they're chosen appropriately. They don't, like my patient with the defibrillator that had to be replaced twice, they put in very few defibrillators, like 1 or 2 a year. And they have great technology, but only for those who can afford it. So here's a cardiac ultrasound and a cardiac catheterization laboratory. So not really used that heavily. So when we met with the cardiologist at this institute and asked them, like, what do you see as the greatest problems in terms of heart disease? And they said, well, we still get a lot of patients coming from remote parts of the country, the western part of Nepal, with very advanced stages of rheumatic heart disease, where there's really not much that you can do with their heart failure. If they had come earlier, they could have had a valve replacement, but at the point that they're referred into the city, it's too late to do anything. And that's very discouraging and sad. And they talk about, we should just give penicillin to everybody in these villages just to prevent rheumatic fever. And then they're also seeing more young patients with coronary artery disease, and that's just the start of an epidemic of coronary artery disease that's likely to occur in Nepal, as it is in India now, and sub-Saharan Africa is still more in the infection and famine and ravages of war stage. So worldwide, most heart attacks now occur in low-income countries. And that's because there's just such a larger population there, and also because of all these factors, what we call a hostile cardiovascular environment. So lack of exercise, fatty diet, a lot of smoking still. HIV survivors are more likely to have heart disease. Air pollution is a really big problem. Urban migration, a lot of financial stressors. Climate change possibly contributing in some parts. And then there's a genetic susceptibility of certain ethnic groups. Very sensitive to salt, so tend to get high blood pressure, insulin resistance with abdominal obesity, low birth weights. And then of course these countries that are facing this epidemic of coronary artery disease have poor governments, limited national resources, and it's going to be pretty much, it's going to be horrible trying to face this in addition to the infections that occur earlier on. So there are people who are trying to make a difference, obviously, in Nepal, and one of these is Dr. Arjun Karki, and he's the Nepali doctor who had this vision of building a medical school to train physicians for rural Nepal so that people, so there'd be doctors in these remote areas who would see patients with rheumatic heart disease, whatever, treat them, and then refer them in for surgery before it's too late. So that was kind of the vision, social justice and equity. And he trained in pulmonary medicine at Johns Hopkins in Baltimore. And his great talent was basically making connections with people. That's a tremendous talent. So he garnered support of physicians and medical education leaders from around the world, and very well connected to the government in Nepal as well. And so every year there would be an international advisory board meeting, and Kim's not in this photograph, but usually he's there at this meeting. David Zakas is our Director of Global Health here at the University of Alberta, and here he is at a meeting with the Nepali Prime Minister a year ago. And there's Bob Woolard from UBC and University of Calgary as well. So in Nepal, people really, ceremonies are very important. So these meetings, it was very important for Arjun Karki to bring these people from around the world to meet with the Prime Minister, so the Prime Minister would understand how important his support was for the Patan Academy of Health Sciences. The resources at the medical school, they were kind of like a portable at a high school, I would say. Really basic. So this was the classroom, and this was one of the discussion rooms, like for small group discussions, and the library had some textbooks. And there were computers here in this, enough computers for about half of the students. So basic resources. The first class of students entered in 2010, and this is a 6-year MBBS program, and they really tried to get students from rural Nepal because those are the students who are most likely to go back and work in those environments. And they had scholarships for more than half of the students. Now, there are many medical schools in Nepal, and every year there's about 2,000 students that graduate from medical schools. But most of those are private schools, and the students come from wealthy families. And so as soon as they get their medical degree, they go to high-income countries to do their residency, and they seldom come back to Nepal other than to visit their families. So this school really is trying to train physicians who will stay in Nepal through scholarships and early exposure to rural medicine. So these are different strategies they use to excite students about working in rural Nepal. So taking students who came from small villages, giving them scholarships, and some of them are government scholarships and some are just from international benefactors. They do rotations in rural communities right from first-year medical school. And in these poor countries, people travel in very small circles. So, the streets of Kathmandu, they don't have names. And if you ask someone a local who lives there, where a restaurant is like 3 blocks away, they won't know because that's just not where they go. So they don't have information about things that they don't need to know about. So it's really, some of these medical students who grew up in Kathmandu, they had never been outside of Kathmandu. So going to a rural community was really a big adventure for them, a big experience. In addition, what this medical school is hoping to do is improve on their telemedicine support. And that's obviously very important when you have physicians working in small rural communities in a country that has such geographic challenges, barriers. So the challenges: lack of adequate internet connectivity, unavailability of power supply, and then limited local expertise in this technology. So for example, we use remote diagnosis and directed therapy all the time here in Canada. It's really wonderful. So for example, if someone is having a heart attack, is having chest pain in Riverbend, so they call 911, and the paramedics go out there. the paramedics will do an ECG in the home, and that ECG will be transmitted wirelessly through cell phones, basically, to the cardiologist or emergency physician who's on our vital heart response team for that day. And that person will look at the ECG and say, yeah, this person's having an infarct. Give him aspirin and a medication like streptokinase called TPA, TNK. And the paramedics will start the IV and give the medication en route to the hospital. So, I mean, that's wonderful. And theoretically, that could be done in Nepal as well. But it can't. Because first of all, there are no paramedics. You know, if someone is sick, then their family either carries them to the hospital, or they take like a tuk-tuk, a little van, you know, public transport. There are 2 ambulances, I think, in the city, but they're just like taxis. There's no paramedic, there's no health personnel in them that would resuscitate the patient. So, you know, there's no way they could do an ECG. It's not just the technology, it's all the education and knowledge that has to come along with it before you could, you know, make a diagnosis and then direct therapy to the people who are on site. So there's a lot of technology, but really hard to use in countries like Nepal. So what they aim for mainly is like curable, affordable, accessible therapies. What I think of as low maintenance therapies. So for example, putting in a pacemaker, that's low maintenance. You know, it's a one-time deal. The person has a really slow heart rate, the surgeon implants a pacemaker, and the person's fine for 10 years or so. And that's great. There's no other medications you have to take. Another one is mitral balloon valvuloplasty. If a patient has a valve that's not opening well, the cardiologist can thread a balloon through that valve and inflate the balloon to open up that valve. And those catheters are reused in countries like Nepal. We don't reuse them here. And that's wonderful too. But when you're talking about a valve replacement, well, that requires ongoing blood thinners that require monitoring. Or coronary artery disease, that requires antiplatelet medications to prevent other heart attacks. So that chronic diseases are a lot more complicated in terms of ongoing medications and follow-up that's required. So, you know, limited. Most of our technologies aren't curative. They help, but they don't cure. They require maintenance. And really important to use simple technologies because everything breaks down. Like the ECG machine broke down when I was there, and that's a really simple technology by our standards. And you know, we couldn't fix it. You try to fix whatever you can, as best you can, and people are very helpful. But if a part is missing, well, you're out of luck. So cell phones, though, are ubiquitous. And wireless internet is available throughout most of Kathmandu Valley. So cell phones are a great technology, accessible, cheap technology. 70% of the world's 5 billion cell phone users are in the developing world. So, you know, everybody has a cell phone in Nepal. They're not smartphones though. Like an iPhone, that's an incredibly wonderful thing for them. Like they just have the old cell phones. But they're very good at texting on them. 90% of the world's population has access to a wireless phone signal. And in India, even a third of people living in villages have mobile phones. And it's expected that by 2015, 60% of the mobile phones will be web-enabled. And, you know, there's a lot of good that's come with increased information. And Thomas Friedman writes about the rise of the virtual middle class. And that's just because of the connectivity that we have via the internet and cell phones. So even though people are still poor, they still have like dirty water and no sanitation and garbage everywhere. They know that life could be better. So they demand more. Demanding of rights, roads, electricity, uncorrupted police, good governance. And certainly small projects have shown that technology can improve life in these in these low-income countries, and there's a number of small projects using cell phones, like to tell people when they should use power. It's cheaper, and then when to avoid unprotected sex. So that can improve life for small groups of people. But this is what you're faced with, and this is just the newsletter that we got. I got it from Kim and David Zakas. I mean, it was amazing to read this newsletter. That just came out, and these are like the stories in the newsletter. So the corruption, politicians, there was an election earlier this week in Nepal, and politicians were offering meat and liquor for votes. 3 million people in Nepal are illiterate. There's a serious hunger problem, but it's not as bad as it was, because now Nepal is like 49th in terms of hunger out of 120 countries, and before it was 60 out of 120. Open defecation is still a problem, and there's a district in Bhaktapur that just had toilets now for every household, and that was a wonderful thing. So toilets are amazingly wonderful, as is running water. Lawlessness, now that's really concerning to me, the lawlessness. So there were several stories about hospital workers and doctors attacked when a patient died. So, that never happens here. We may get sued once in a while, but that's very different from, angry relatives punching you and stabbing you when a patient dies. So that's horrible. And then they talk about roadkill, and these are buses that crashed into rivers. And these are people dying, the roadkill. And violence, rape's common, laws not enforced, and then 80 to 90 witches are killed annually in Nepal. That's hard to believe, but this was in this newsletter. So these are the kind of beliefs people have. Very scary. And then there's goat drowning. So in one town, they periodically drown goats because they think that will prevent their children from going into the pond and drowning. So instead they drown goats. So just really very different. So technology has limited ability to make a big difference in people's lives there when you don't have government and infrastructure that would support it. Science and technology are the products of affluent countries. And those countries, and especially the wealthier people in those countries, benefit in terms of quality of life and improved health. No question about it. And a lot of the improved health that we have is from better infrastructure, like our homes, and not living 30 people in a small space. Low-income countries are left behind in terms of their health and quality of life. And they lack the education and skilled workers to use technology. They lack the infrastructure and political stability that would allow technology to be developed in their countries. And it's really hard to import technology. You have to kind of work with it, become familiar with it, so that when it breaks down, you can fix it. It's not just, sending people some machines. It'll be like the hospital that's locked up in Lukla, You can have technology, but if nobody knows how to use it, it's useless. And this analysis by Fazal in 2003 found that cell phones have not improved living standards in the 40 least developed countries of the world in terms of real per capita GDP. So, it makes some things easier, but these countries are still poor. And I think overall technology increases the divide between the have countries and the have-nots. Flow to low-income countries, so diffusion of new technologies and use of these technologies in low-income countries depends on the ability to implement and maintain these technologies. And that really takes an infrastructure that's lacking in these countries. So you need local policies to promote the learning, like literacy to start off with, human capital and technological capabilities. And ideally, you want these countries to promote local production of technology and not just, be factories that produce technology that's then exported. So you want strategic partnering and not just hosting of production facilities. So Nepal would definitely benefit from a lot of technology, but it has those tremendous barriers that it has to live with. But hopefully over time and with education of the people, that will improve. So, technology, initially, a wonderful thing would be if there was clean water and sewage management and pollution control, improved infrastructure, roads, electricity on a regular basis, central heating for housing, improved health, so just simple things like vaccinations, maternal health, nutrition, diagnosis and treatment of communicable and non-communicable diseases, more use of telemedicine with smartphones that have peripheral diagnostic devices and remote monitoring, database development so we actually have more information about the health of the people. There are disadvantages to technology. I mean, technology, it's an ongoing requirement for maintenance and troubleshooting. You can't just, and the more sophisticated it becomes, the more it seems to break down, and you need a whole industry to maintain the technology. And once you rely on technology, that's our big fear, that it fails. So we still have a lot of paper copies of charts in the hospital. It's taken us a very long time to become partially paperless. And that's because of this concern that we won't be able to access information that can be really important. And then technology, I find, produces a lot of garbage and pollution, like just when you look at all these old computers and electronic devices. And countries like Nepal, it's just so sad because they'll have recycling bins in the tourist areas where you can throw your pop bottles and whatnot, but they don't actually recycle them. They just throw them in with the regular garbage at the side of the street. They don't have recycling facilities. And then one of the problems of technology that I find in our society is loss of simplicity, so loss of face-to-face engagement with other people. And I think that decreases the quality of life. And a person who wrote about this really eloquently is Sherry Turkle. She's a psychologist and sociologist at MIT, and her book is entitled Alone Together. So even though, in Western societies we communicate a lot, it's a different kind of communication through technology. It's easy to turn people off, whereas in real life it's a lot messier than that. So a life not well lived when you rely too much on technology. And then, from Arjun Karki, I just learned in Nepal, I see the barriers, and I think, Kim, you see them too, but they're so used to these barriers, they know that unless they start working on something and believing it can be done, nothing will ever be achieved. So they have huge plans for this very small medical school, to build a school of public health and to have specialty training programs, so huge dreams. And, obviously those dreams will not succeed, not all of them, but at least, it'll get them down the road, and then who knows what will happen. And I think sometimes, I know I tend to dream pretty small. Really important to be open to new adventures and taking risk. Now the risk in Nepal is on a different scale, and it's not the risk of climbing mountains. The risk in Nepal is basically of dying from diarrhea, from cholera. It's just, or from dying because a bus hits you. The buses, they're just all over the road. The traffic is not in the lanes that they should be in. I mean, there's no lanes. So, it's a huge risk. Just living in Nepal is a risk, but it's very eye-opening to kind of live with the people there and see what they have to contend with on a regular basis. And one of the big lessons I learned is how we tend to see things from our own perspective, and other people with, from different cultures or different experiences, they have totally different perceptions. And the story that I'll always remember is this young doctor that I was talking to one day who told me about some work that he'd done on medical stations in remote areas in the mountains. And I said, well, must have been beautiful up there in the Himalayas. And he just had this very serious expression. You know, they're very polite, but he obviously was disagreeing with me. And he said, well, I was cold, hungry, and tired while I was in the mountains. And I'm like, oh yeah, but it must have been beautiful to be in the mountains. And he says, well, I was cold, tired, and hungry for 3 months. And then I realized that my experience of the mountains is just so different from people who live there. Because when we go, it's like to climb a mountain, and we have all our modern, lightweight, very warm parkas and equipment and crampons and whatnot. And we have lots of food. And, you know, it's a challenge, but it's nothing like living there for months on end and being hungry. Very different experience. And so never have to always try to realize, keep learning that, you know, other people just have a totally different perspective, and to try to understand their perspective, certainly before you try to give them any kind of aid. And when you help others, or when you try to help others, first of all, you don't really know the effects you have. Some may be visible, many aren't. But if you do try to help, it comes back to you. It makes you feel a lot better. And you don't really need to travel to do all of this, because there's the technological have-nots right here in Edmonton, you know, and I think we're very fortunate, and many people aren't, and it's nothing that we've done really that made us deserving of what we have. And we should always try to help those who, in our own city, who have much less than we do. And it won't be through technology, it'll be through like food and shelter, and then education, I think, is extremely important. And to me, technology comes later. You have to learn to read and write first. Okay, that's all I had to say, but thanks very much for your attention.
So, you know, it may seem to some of you that this is a bit remote from your own life, like, you know, this has less to do with your own life than most of our lectures, but I really feel sort of the opposite. And then if you look at my own life, the last 12 hours, 6 hours, so the main thing I've been doing in the past little while is working on the MOU as a part of this project. Now, you may think that's a very complicated process, the MOU between the university here and, you know, the institution there. Actually, at least at this place, it's regarded as ideal if it involves only 3 people. So that's what it does. So there's Rennie Khan, who is sort of the university's person in creating MOUs. And there's me here, and there's one person there, and we're kind of negotiating the language with the idea that because of the university budget cuts, which I'm sure one way or the other affect all of you sitting here, that we need to get all these things signed and in order by the time that the medical school accreditation visit occurs in March 2014. So it's not just our project, but every external project. They're hoping to get the paperwork completed. And in a lot of other ways, I think this is very tangible, practical in ways you may not realize. This project now involves so many people that whatever area you're interested in, now that there are about 23, 24 full-time faculty in the Faculty of Medicine and people outside who are involved in this project, there's probably, you know, if you think of degrees of separation kind of thing, there's somebody that you know who knows somebody who's directly working in this project. So it's big, it's tangible, it's happening right now. One of the interesting questions about the MOU you may think must be very boring and complicated. Well, it's the question whether it should deal with the time forever, whether it should contain no timelines, right? This is just an agreement between the two institutions without an end, or whether it should be for 5 years and, renewable. And that's kind of exciting to think about the difference, that at their end, they don't see any reason for the 5 years. They'd sort of like it to be, expression of an intent for their institution and ours to work together sort of forever or for the foreseeable future. So I would also tell you that in terms of student feedback, it's fascinating. What happens with this lecture, at least in the past, is some students have said it's the best lecture in the whole course, and others have said it's the worst lecture. It doesn't belong. What is this doing here? Why should we have to listen to this? And so if you feel at one end of that spectrum or the other, I'm just saying this is what happens. But I'm very proud. I think you can't talk about technology and the future of medicine without talking about how does this play out in the poorest countries of the world. I mean, it's just not logical to take a kind of, elitist attitude that we're only interested in those countries who can afford stuff. And we're only going to talk about these issues in the countries that can afford stuff. I think we also equally need to spend time thinking about, and the thing that I'd also like to emphasize, as you listen to this lecture and you think of all the problems there, it can seem overwhelming. And you can get the impression that you personally couldn't make a difference. But actually, in a situation like this, you certainly could. Each and every one of you could find something here that you could personally change. And it's easier, in a sense, in a country where there's so much wrong. In most normal first world countries like Canada or the US, you would never meet high officials. You'd never meet the Minister of Health, Prime Minister. It's just the gulf between you and them. It would never happen. In a country like this, it will happen. You can meet the highest people you can think of. And so, in a sense, you can get more done for that reason. Some things just can't be done. But it's sort of fun to think about it that way, that the microcosm in which you live changes entirely. So, anyway, I'm sure you have questions.
So I'm wondering if you see a relationship between the influence of the Western society. We have all this garbage, but are we also contributing to the increase in diabetes because of the diet that we're putting onto these people? They don't have, genetically, they have a higher susceptibility to what's killing us.
Well, I have to say, like in Nepal, they seem to still have quite a traditional diet. But what you're describing, we've certainly seen among our own indigenous people, like the Aboriginal people here, our native people. They have they eat, the food that we all eat, but they have a genetic predisposition to diabetes, and so we see a lot of diabetes and renal failure among the natives in Canada. In Nepal, they haven't really changed the diet that much, but the people who shop in the stores that have the Western food are mainly expats, and the wrapper, most Nepalis will still buy vegetables from vendors on the streets, like they bring food in from the farms that they grew. So it's still kind of, they have stores, but the stores sell things, I never really bought, they sell candies, and phone cards, and water, bottled water. That's what I remember in the stores. So I don't think their diet has actually changed that much in Nepal specifically.
And the other one I have is, what do they do with the goats after they drown it?
What do they do with what?
The goat.
No idea what they do with the goats. Sometimes they behead them, I know that. But they have a lot of like customs involving animals. Like it's a Hindu society with many different gods, and there's shrines. Like religion is a big part of their everyday lives. So it's very beautiful. Like just the coexist. There's some Buddhism, obviously, and Hindu, and they have shrines everywhere. Like the Hindus get all these like roadside shrines, and people make their morning offerings, rice usually and a flower or something, puja offerings. I think that's what it's called. And then there's these Buddhist shrines, and they respect each other's religious shrines. So there's like, yeah, that part's fine. I didn't sense there was any religious, underpinning to violence at any time.
There are times when there are a lot of animal sacrifice, and it's really quite off-putting for most Western people. And so we tend to have the meetings we have there, away from those holidays. I'm not sure it's dangerous in the usual sense. It's just that Western people are put off by this, killing of animals and animal blood and all this sort of thing, and they can't really conceptualize what's happening and why it's happening. So it just doesn't work well to have Western people there for meetings when those ritual sacrifices are being carried out. The movie about Iran, Not Without My Daughter, some of you have probably seen that, and there's the same sort of thing of, the ritual sacrifice of goats and stuff. There's a very bloody scene there that's quite memorable. So, yeah, it is a whole different world, but a world in which we can do a lot of good, and in a way it's easier to make changes to have an impact there than it is. But the other thing, as Bibiana says, is once you decide to do something there, you realize there are similar classes of people back here that we could equally well help. And so there are a lot of lessons. It's not just us teaching them. We learn a lot, not just about specific things, but about life and how life works. I mean, it's good to broaden your own kind of expanses through.
Yeah, the sense of community is very strong there. I mean, the families are so important. Sabita Rana, one of our friends who's an immunologist, she's from Nepal, but she trained in Australia. She came back to Kathmandu just because her mother developed diabetes. Her parents were getting older, so that very strong duty to parents. And no matter how good your life is anywhere else, you come back and look after your family. I was very impressed by that. Here, technology hasn't enabled us to live easy lives without much reliance on family or other people necessarily. I mean, we rely on our plumbers and handyman and all those people. We pay for those services. It's a little different. We contract out, but that's not the way it is there. Like when you have a problem, your family helps you, or friends of the family. Like that's how things work. And I think that's actually pretty nice.
Yes. No, there are many things. You talked about Arjun Karki. Once in my life, somebody spent an evening with me just to find out what makes me tick and what my real beliefs about, and just spend enough time talking to me to find out what I really think about life. And that's the only time that happened. And the intent
That's why he's so good.
The intent was very clear. Arjun said, we're just going to spend enough time together that I really get to know you. And so he asked me about philosophy and religion and, all those sorts of things. And I don't know whether it was valuable for him. It was certainly valuable for me to suddenly have to account for myself in that way, nobody in our society here would ever do that. I mean, maybe they'd have that intent, but they wouldn't really succeed, because we don't do that. You know, it's kind of accidental. A lot of our most deeply held beliefs we never reveal to anybody, and certainly nobody sits you down and sort of says, tell me for 4 hours all about yourself, everything, you know?
But that's so wonderful, right?
Yeah,
And,
yeah.
Or, you know, you go into a small shop and the owner wants you to drink tea before you talk about what you might want to buy in the store. So it's just very personable, and
Yes.
of course it's all, you know, just to make you in a more suitable frame of mind so that you'll buy a more expensive thing, but it's still nice to stop and interact with people.
Yeah,
And many examples of that.
yeah. And I think, as I've said, if you think about the value of this course, and now I'm kind of thinking more, now that I've succeeded in making it a medical school elective for first and second year medical students, now I think, well, geez, you know, is this just a trick? Did I trick them into this, or is it really good? And no, I'm thinking that it's really good, but only if we keep the balance. You know, if we got rid of everything about old-fashioned values, and, you know, if we just talked about, you know, technology stuff, first world stuff, I think it'd be a corruption of the medical school curriculum, as long as we keep stuff like this, you know.
You know, one thing I've learned is that everything is both good and bad.
Yeah.
So the high tech and all that
Right.
is good, but there's a bad side to it as
Sure.
well.
Yes.
Yeah. Less, you know, direct contact with
Yeah.
people, less caring.
Yeah. No, there are, I'm sure this doesn't happen to any of you or people in your family, but there are Japanese young people now who never leave their rooms. I mean, who their entire lives are, you know, behind the screen. And yeah, I mean, I guess they come out for meals and things, but, you know, basically, they have no life outside the online life.
And honestly, most of us in medicine, we'd be very careful about the high-tech interventions we would want.
Yes.
Because we see the downside too. I mean, they all have complications.
Yeah. You may know that I have a kind of alter ego, a guy entirely opposite of me. His name is David Crippen, and he runs the critical care medicine email groups. And they talk about this a great deal, futile care, you know, spending hundreds of thousands of dollars on end-of-life care, which benefits nobody, really. I mean, it may make the family feel better, but the patient certainly isn't benefiting.
No, because
society
the patient's
isn't.
comatose, usually.
Yeah.
So
Yeah. And in the U.S., it's becoming harder and harder to get out of that scenario when, you know, the resources can be accessed when the family clearly wants this. You know, I mean, you just end up in crazy situations. Anyway, thank you very much. So next week, just to remind you, we've switched the lectures so that anthrax and bioterrorism, the one lecture that'll never be on YouTube, is on Tuesday. And then Julie Lin Wong is back on Thursday, the 28th. And I think she intends, you don't all have to be here for this period, but we have the room through until 5. And so she plans to do both things, to both complete everything she needs to write this paper with you guys about the social media and medicine, and also to do some more with the 3D printing surgical tools. So those of you who have the time and the interest, want to stay, I think, and then that Nerd Night is the same night, so we have to finish by 5. Angus is going to be so tired at the end of Thursday, but it should be an exciting night. Anyway, so thank you very much, and see you next week.